So the Candor phase 3 trial is a randomized phase 3 study focused on relapsed and refractory myeloma patients who've received 1 to 3 prior lines of treatment. This study is very important in the context of the current available regimens we have in the United States especially, and the fact that majority of patients are on lenalidomide maintenance as they are relapsing. Of the 6 available regimens, 4 contain lenalidomide, and so for patients who are len refractory or len exposed, we kind of have limited options. For this particular phase 3 trial, prior Carfilzomib therapy and anti-CD38 antibody use was allowed, but patients had to have at least a partial response to that prior treatment and discontinuation with a drug-free interval of 6 months. The randomization schema was a 2-to-1 randomization schema with every patient being randomized to the Carfilzomib Dexamethasone arm. 2 were randomized to the Daratumumab Carfilzomib Dexamethasone arm. A total of 466 patients were randomized, and treatment was continued until relapse, progression, or intolerance to therapy. Of note, the schema for Carfilzomib, Dexamethasone, and Daratumumab was a little different compared to the weekly dosing phase 1 study that led to informing this particular phase 3 study. For patient convenience, the first dose of Daratumumab was split into 2 doses and given cycle 1 day 1 and cycle 1 day 2 in doses of 8 milligram per kilogram, whereas for the subsequent doses, the dose was 16 milligram per kilogram. The primary endpoint was progression-free survival. Key secondary endpoints were overall response rate. Importantly, MRD negative CR rates at 12-month time point, duration of response, overall survival, time to treat, as well as treatment emergent AEs. So this is the punchline slide, I guess. The primary endpoint for this study was met with KD Daratumumab demonstrating significantly longer progression-free survival compared to KD. The median PFS on the KD arm was 15.8 months, whereas that on the KD Dara arm was not met. The hazard ratio of the study was 0.63 in favor of KD Daratumumab, and what that translated to was a 37% reduction in the risk of progression or death on the 3-drug arm compared to the KD in patients with relapsed refractory multiple myeloma. At a median follow-up of 17 months, there are no differences between the median overall survival between the 2 arms of the study. So as I mentioned about the clinical context, this is perhaps one of the more important subgroups within this particular study. Patients who had prior lenalidomide exposure or len refractory disease, and in both those subgroups, the KD arm had a median PFS of 12.1 and 11.1 respectively, whereas the median PFS has not been reached on the KD Daratumumab arm. Of note, proportion of patients who had prior exposure to bortezomib were 90%. Prior exposure to len was in 42% of the patients, and len refractory patients, 33%. So the PFS benefit was maintained not just in other subgroups, but in these 2 clinically meaningful subgroups as well. The overall response rate on the 3-drug arm was 84.3% compared to 74.7%. And as I mentioned, the striking feature of MRD negative CR rates at 12 months was quite important. 12.5% in the 3-drug arm compared to 1.3%. And as we've seen with other Daratumumab triplet combinations, these responses tend to deepen over time as well. Median time to response was 1 month in both the KD Dara and KD arms. In terms of safety profile, there were numerically higher grade 3 or higher events on the Dara KD arm at 82.1% compared to 73.9%. Serious AEs were also higher, but the median duration of treatment was higher on the 3-drug arm, 70.1 weeks compared to 40.3 weeks. Interestingly, we saw lower degree of grade 3 or higher cardiac failure in the KD Dara arm compared with the KD arm. So 3.9% versus 8.5%. We're not sure about how this happened. We were a little surprised with this particular finding, but we're looking into more details on the baseline features of patients in terms of comorbidities, whether there were any differences. Regardless of the fact that there were numerically higher grades of grade 3 or higher AEs, the treatment discontinuations due to AEs were similar in both the arms of the study. So in conclusion, treatment with KD Dara resulted in significant PFS benefit compared with KD, with 37% reduction in the risk of progression or death. Patients treated with KD Dara achieved deeper responses than patients treated with KD, nearly 10 times higher MRD negative CR rates at 12 months. The PFS benefit with KD Dara was maintained across pre-specified clinically meaningful important subgroups, such as lenalidomide exposed and lenalidomide refractory patients. AEs were generally manageable, and incidence of AEs leading to treatment discontinuation was similar across the two arms. So to summarize, the final conclusion would be that the KD Dara should be considered a novel, efficacious, and tolerable IMiD-free treatment option for relapsed refractory multiple myeloma. Thank you.